Hi guys, welcome back everyone. So today we will be doing a recall of UPSC CMS examination. Recall, well, you have already got the question paper. Let's see if you answered the right answers. Okay. Now, I'm not going to take much of your time. I'm directly starting with the questions. So this is going to be our first question from medicine. A 35-year-old man presented with serial blood pressure recordings of 140/90 or higher than that. Which of the following signs is not a clue for underlying cause of secondary hypertension? Now today, hypertension is defined as BP of more than or equal to 130/80. This is the current definition of hypertension. If all of his readings were above 140/90, clearly he is having hypertension. So diagnosis is sure, hypertension. Now the causes for hypertension are classified as primary or essential hypertension, where you do not have an underlying identifiable cause, and then you call it as a secondary hypertension when you have an underlying identifiable cause. Majority of the cases of secondary hypertension that we see are because of endocrine disorders, right? So causes for secondary hypertension include endocrine disorders and renal artery stenosis. Endocrine disorders, renovascular hypertension, that includes renal artery stenosis. And when we are talking about endocrine disorders, please remember you can have secondary hypertension in patients with Cushing syndrome, in patients with pheochromocytoma, Okay, even hyperthyroidism and hypothyroidism can cause hypertension. Hyperthyroidism causes systolic hypertension, while hypothyroidism causes diastolic hypertension. I'm not going into the exhaustive listing. The common ones that we need to be aware of, I have listed here. Now, what the question is asking, which of the following signs is not a clue for an underlying cause of secondary hypertension? Secondary hypertension you can also get in patients with coarctation of aorta. Okay. So, which of them is not suggestive of secondary hypertension, right? If you get a patient with hypertension and there is radiofemoral delay, there is a significant delay between the pulse reaching the radial artery and pulse reaching the femoral artery, then you have radiofemoral delay. Radiofemoral delay is typically encountered in patients with coarctation of aorta, and coarctation of aorta is known to cause secondary hypertension. So this can be encountered. Okay. Then enlarged kidneys. Enlarged kidneys are usually seen in patients with ADPKD and early stages of diabetic nephropathy. Both of them are known to cause secondary hypertension. So renal disorders are also known cause, not just the renal artery stenosis, but renal disorders are also known cause for hypertension. You talk about the acute glomerulonephritis, you will have hypertension. Renal disorders are known to cause hypertension. So this can also be a clue towards the secondary hypertension. Bull neck and buffalo hump. Bull neck, buffalo hump, bull neck, moon face, right? Centripetal obesity, pink purplish striae, they're all pointing towards Cushing syndrome. So if I get a patient with hypertension and he has these findings, I would be strongly thinking about Cushing syndrome. So in that case, again, it could be a clue towards secondary hypertension. So you get it here also. But vitiligo is primarily an autoimmune disorder. It might point towards presence of other autoimmune disorders in the patient, but that need not always be associated with secondary hypertension, right? So that's why this becomes my answer. Presence of vitiligo doesn't point towards secondary hypertension. Everything else points towards secondary hypertension. Okay, I hope you have answered it right. Now let's go to the next question. A 71-year-old male presents with headache, dizziness, nausea with palpitations. So there are some serious symptoms going on there, and patient is already on treatment for diabetes and hypertension. So is a non-diabetic and a non-hypertensive that we're talking about. Blood pressure reading is 220/140, right? Quite high. Which of the following statement is or are correct? This is a case of hypertensive emergency which can be managed by intravenous sodium nitroprusside. Second, an immediate normalization of blood pressure should be the target. Secondary causes of hypertension like renovascular disease are uncommon in a patient with hypertensive emergency. Select the correct answer using the code below. Okay, now definitely this is a hypertensive emergency. Why? When do you call it as hypertensive emergency? When there is acute rise in blood pressure, usually above 180 by 120. Now, if the BP just shoots up, it's not hypertensive emergency. We will simply call it as hypertensive urgency. But when BP shoots above 180, 120, and that is accompanied by hypertension mediated organ damage, like developing cerebral edema, heart failure, those are considered as hypertension mediated organ damage. The symptoms of hypertension mediated organ damage can be in the form of headache, nausea, vomiting. So because we are having the symptoms here, I am going to take this diagnosis as hypertensive emergency. Now, whenever we have hypertensive emergency, the point to note is we need to lower the BP quickly, but immediate normalization is not the goal. It is in fact harmful. So what we should be doing, in the first 1 hour of recognizing the hypertensive emergency, you have to decrease the mean arterial pressure by not more than 20 to 25%. Whatever is the current mean arterial pressure, drop it down by 20 to 25% max, not more than that. And then slowly you will bring the BP down to a value of around 160 by 100 over next 2 to 6 hours. So at the end of 6 hours, roughly, my BP should be around 160, 100, not normalize immediately, right? And to achieve this decrease in BP, of course, we need to have a controlled drop in the blood pressure. So I should preferably use drugs which can be given as IV infusion. Oral drugs, of course, will not help me to bring the MAP by 20 to 25% within 1 hour, right? And if I use sublingual, I do not have a control on the BP lowering, because once you take the sublingual medication, it is in the circulation. Whether it will drop by 20%, 25%, 100%, 50%, we don't know. So that's why we prefer drugs which can be given IV infusion, because we can adjust the rate. If you feel like BP is dropping too rapidly, you can decrease the infusion rate or maybe temporarily hold it. Or if it is dropping too slowly and it is not as per your expected target, then you can increase the infusion rate. So that's why we prefer IV infusions whenever we need to have a controlled lowering of the blood pressure. So that can be in the form of either IV sodium nitroprusside or nitroglycerin or even labetalol. So these are the agents that we use in hypertensive emergencies. So now looking at the statements, this is a case of hypertensive emergency which can be managed by intravenous sodium nitroprusside. Yes, this is true statement. Second, immediate normalization of the blood pressure should be the target. Absolutely not. In first 1 hour, we are only lowering the MAP by 20 to 25% and we are reaching 160 by 100 by around 2 to 6 hours. Secondary causes for hypertension like renovascular disease are uncommon in patients with no. The essential hypertension or primary hypertension is less likely to manifest in the form of hypertensive emergency when you compare it to the secondary hypertension, because you have an underlying cause. If you just try to give antihypertensives but underlying cause is not fixed, like pheochromocytoma, it's not fixed, your BP is not going to come under control easily. Very high chance that you might end up with hypertension mediated organ damage. So this statement is also false. So then what's going to be my right answer? Only statement 1 is true. So option A becomes my correct answer, right? Okay. Already I'm liking the way the UPSC CMS has framed questions. I respect UPSC CMS questions more than the questions that we get in FMGE, INI-CET or NEET PG, because they put out questions which are more relevant for clinical practice. As a clinician, you should be aware of, rather than asking you about some rare mutations or some rare syndromes that we commonly get to see in INI-CET. Okay, now the next question. Consider the following statements regarding Takotsubo cardiomyopathy. I think you're all aware of stress cardiomyopathy or broken heart syndrome, right? Okay, now let's look at the statements. There is acute right ventricular dysfunction characterized by dilatation of the right ventricular apex. It can be precipitated by acute emotional stress and is frequently associated with underlying psychiatric disorders. Symptoms and ECG findings often mimic acute ST elevation MI. ventriculography shows normal left ventricle and apical ballooning of the right ventricle. Okay, let's understand a little bit about Takotsubo cardiomyopathy. So what is Takotsubo cardiomyopathy? Whenever someone is subjected to sudden emotional stress, and when I say sudden emotional stress, intense emotional stress, especially in people who are already prone to react to stressful situations, who are prone, people already having neuropsychiatric illnesses, like a known case of depression or known case of generalized anxiety disorder, they are considered risk factors. Having neuropsychiatric illnesses and female gender are considered as risk factor. Okay, now these people, when they are subjected to sudden emotional stress, they will produce a large amount of catecholamines, right? There will be catecholamine surge or storm, not the small amount of catecholamines, adrenaline, noradrenaline, dopamine that get triggered whenever we are a little scared of seeing a snake on the street. No, not that level of adrenaline, noradrenaline, or not the level of adrenaline, noradrenaline that gets released when your professor catches you inside the campus smoking. No, intense stressful stimulus, intense release of catecholamines, right? That is what I am calling as catecholamine storm. Literally, your bloodstream is flooded with adrenaline, noradrenaline, dopamine. Now, what these catecholamines do? They hyperstimulate part of the heart. Hyperstimulation mainly affects the part of the heart which I can call as the left ventricular outflow tract. It means this part from where the blood actually goes towards the aorta. There is hyperstimulation, okay, and there is less stimulation of the apex. So when the heart starts contracting, because of the hyperstimulation, this part is already narrowed, right? It is kind of obstructed. So whatever pressure that builds up inside the ventricle will not be channelized towards the aorta. So that pressure leads to the apex of the left ventricle dilate like a balloon, and when it dilates like a balloon, that is what you call as apical ballooning. You are calling as apical ballooning. Okay, and now this part of the left ventricle under hyperstimulation has spent whatever metabolic reserve it had, like glucose and ATPs. It's all spent, so it becomes stunned. It doesn't have sufficient glucose to contract, so it becomes hypocontractile, literally looking like a balloon, right? And because it is lacking ATPs, like there will be some degree of muscle injury, and that will leak the troponins. You will also see some ECG changes. So these patients often present with clinical features resembling ST elevation, MI, or heart failure. So the story goes like this: some sudden emotional stress, catecholamines released, they block the outflow tract, understimulated the apex, so apex eventually ended up dilating. There is myocardial injury. That's why patient is presenting with STEMI or heart failure like clinical picture. Okay, but how do I get to know that I'm actually not having a case of STEMI or heart failure? When you look at the echocardiography, you will notice the apex has become like a balloon. Normally it is conical shaped, but it has now become like a balloon. Or if you do ventriculography where you give a dye, then the dye will accumulate into the ventricle and shows that its shape is more like a balloon, right? But which ventricle is affected here? It is the left ventricle, right? So there is a LV apical ballooning. And now the shape of this left ventricle is that of the Japanese vessel used for capturing the octopus, and that is where the condition derives the name Takotsubo cardiomyopathy. Okay, so now let's see if we can answer it. There is right ventricular dysfunction characterized by? No, there is left ventricular dysfunction. So this is false statement. It can be precipitated by acute emotional stress and is frequently associated with underlying neuropsychiatric disorder. True. Females and patients with neuropsychiatric disorders are more prone. Symptoms and ECG findings often mimic acute ST elevation MI. That's also true. Either MI or heart failure mimics. Ventriculography shows normal LV and apical ballooning of the RV. No, there is ballooning of the LV and RV will be normal. So this is also false statement. So how many statements are true? Statement 2 and statement 3 are true, making option B as our correct answer. Yeah, they are asking which of the following above are correct. Okay, good. So we got our answer. I hope you have marked the right answer. Okay. Now moving on to the next question. What is the question about? Tumor plop is a characteristic auscultatory finding seen in which of the following conditions? Atrial myxoma, arrhythmogenic ventricular cardiomyopathy, constrictive pericarditis, dilated cardiomyopathy. Okay, so first of all, I don't have any particular abnormal sound to hear in arrhythmogenic right ventricular cardiomyopathy. In constrictive pericarditis, you do hear an abnormal sound which is called as pericardial knock, not the tumor plop. We hear pericardial knock. Okay. Then in dilated cardiomyopathy generally leads to LV dilatation, right? So in a dilated LV becomes compliant. So when I try to fill the blood during the passive filling, I can produce a sound which is called as S3. So you may often hear S3 in dilated cardiomyopathy patients. Tumor plop is heard in atrial myxoma patients. That's the correct answer. Now, what is this tumor plop? Like, let us say this is left atrium and this is left ventricle. For that matter, even right atrium can develop a tumor, which is atrial myxoma. So let us say I have developed a atrial myxoma here. So this round is the tumor, and usually the myxomas are pedunculated sessile tumor. So they keep moving, right? So with the blood, this tumor can come and occlude into the mitral orifice and then move back again. So this engaging and disengaging of the tumor into the mitral valve can produce a plopping sound, and that is what we are calling as tumor plop. So tumor plop is typically encountered in atrial myxomas. So right answer is simple, atrial myxoma. That was a pretty straightforward question. Next, Aschoff nodules are pathognomonic cardiac findings in which of the following condition? This is a straightforward pathology question and I'm sure you have answered it. Aschoff nodules are pathognomonic for rheumatic carditis, right? For rheumatic carditis. What is rheumatic carditis? The involvement of heart in patients with rheumatic fever. Heart is not the only organ affected in rheumatic fever. You also have the involvement of nervous system where patients can develop Sydenham's chorea. You also have the involvement of skin where patients can present with subcutaneous nodules, erythema marginatum. You also have joint involvement where patients can present with migratory polyarthritis. But when heart gets involved in the rheumatic fever, we call it as rheumatic carditis. And in the carditis patients, if you do the biopsy of the heart, you will notice Aschoff nodules. Okay, now let's move to the next question. What's the next question? Consider the following statements regarding Eisenmenger syndrome. A patient with severe and prolonged pulmonary hypertension, the right to left shunt gets reversed to left to right. There is marked cyanosis which may be more apparent in the feet and toes than in the upper part of the body. This is true about the Eisenmenger syndrome. You will have predominant lower limb cyanosis in comparison to the upper limb. It's called differential cyanosis. Antihypertensive which cause peripheral vasodilatation can exacerbate the shunting and worsen the symptoms. Okay, let's understand a little bit about Eisenmenger syndrome. Now, let us say there is an individual with a ventricular septal defect. Okay, now in a patient with ventricular septal defect, what will be the direction of flow of blood? See, if you look at both the ventricles, generally left ventricle is more muscular than right ventricle. And because of it, whenever it contracts, it produces more pressure than that of the right ventricle. So that's why during systole, the blood tends to move from the left ventricle to right ventricle, because LV produces more force than the RV. This is the normal direction of flow. So if someone is having VSD, I'm expecting him to have left to right shunt, and it's not a big deal because when the blood comes to the right, goes to the lungs, gets oxygenated, and then comes back to the left again, and then comes here, goes to the tissues. So we are not mixing the oxygenated blood with the deoxygenated here. But the problem is when more and more blood starts coming to the right ventricle, RV is getting more blood. So RV is the end diastolic volume increases, or in other words, preload increases. Because it's getting more blood, it has to put more efforts to eject that blood to the pulmonary artery. So when it starts handling more blood, when it starts putting more effort, it starts becoming muscular. You consistently go to the gym, you will become muscular. So once RV becomes more muscular, its force of contraction also starts increasing. As more and more transfer of blood occurs from LV to RV, RV starts developing more and more muscle mass. So somewhere down the line, in future, one day, the RV becomes more muscular than LV, and then the RV's force of contraction will be more than that of the left ventricle. So in that case, the blood flow now reverses. The blood will now start flowing from right ventricle to left ventricle, right? So when the flow started moving from right to left, we call this phenomenon as Eisenmengerization. We call it as Eisenmengerization, the shunt reversal or flow reversal. This is where the problem starts. Why? Because now right has deoxygenated blood which is getting mixed with the left oxygenated blood and then going to tissues. That's where you start developing cyanosis, right? Lower limb is predominantly be affected. Okay. So in a patient, so this statement is true as we know. Now let's assess whether statement 1 and 2 or 1 and 3 are true. In patient with severe and prolonged pulmonary hypertension, the right to left shunt gets reversed. Okay, so you have already developed Eisenmenger, so shunt is now right to left. And if you develop severe pulmonary hypertension, will the shunt get reversed? Let's try to understand. Now, if you develop pulmonary hypertension, that means pressure inside the pulmonary artery started increasing, right? That's what pulmonary hypertension means. So, if the pulmonary artery pressure is on the higher side, right? If the pressure is on the higher side, for the right ventricle to push the blood into that high pressure pulmonary artery, it becomes difficult. It has to put more effort. So, when it starts putting more effort, more blood also regurgitates into the, not regurgitate, I should not use that word, but more blood shunts into the LV. Basic physics. Whenever a chamber contracts, whatever pressure that builds up inside the chamber will be distributed equally across its wall, not only towards the pulmonary artery. Yes, the right ventricle is putting extra effort to squeeze the blood into the pulmonary artery, but pressure built up will be directed everywhere. So it will also be directed into the LV. So you push more blood into the LV. So if you develop severe pulmonary hypertension, actually the shunting worsens. It doesn't get reversed, right? So this statement is false. It is not true. This statement is clearly false. It's not true. So 1 is false, 2 is true. What about 3? Antihypertensives which cause peripheral vasodilatation can exacerbate the shunting and worsen the symptoms. Okay. Now antihypertensives that cause vasodilatation. So if I dilate these blood vessels, according to Boyle's law, whenever something gets dilated, the volume increases, the pressure decreases. So that means I am lowering the pressure in my peripheral blood vessels. So whenever I lower the pressures in my peripheral blood vessels, it becomes easy for the ventricle to deliver blood there because blood moves from high pressure to low pressure zone. If they were constricted, they will be at high pressure. So ventricle has to elevate, contract with such force that the pressure it generates should be over and above that of the peripheral blood vessels. But now that they are dilated, they are sitting at low pressure. So I have to just rise a little bit pressure and the blood will start going into the peripheral blood vessels. So the amount of effort left ventricle starts putting decreases. So that means the pressure built up in the LV decreases. So if I lower the pressure in the LV, do I facilitate more shunting to occur or do I reduce it? Of course, if the LV pressure is low, RV pressure is high, more blood will come into the LV, right? So shunting increases. If shunting increases, more deoxygenated blood is getting mixed with the LV blood. So patient's symptoms, cyanosis, they all get worsened. So statement 3 is also true. This is also a true statement. Antihypertensives which cause peripheral vasodilatation can exacerbate the shunting and worsen the symptoms. So we found 2 true statements, 2 and 3, and I find the right answer in option D. 2 and 3 are our correct answers. Cool. Let's go to the next question now. A patient presented with pain on the left side of the chest. Okay, what are the differentials you think of? I know you're thinking about MI, but think beyond that as well. On examination, there was dullness on percussion on the left infraaxillary area. Okay, so now what the differentials I can think of? MI is less likely. MI will not give you any dull percussion note. So I would be now thinking about pleural effusion. And then I'll also be thinking about consolidation or pneumonia. I'm not thinking about pneumothorax. In case of pneumothorax, there will be a hyper resonant note. Okay. Now, chest X-ray showed left opaque hemithorax. The moment they say opaque hemithorax, I know there is fluid there, right? So we are almost dealing with pleural effusion according to the patient's story. Which of the following is an indication for tube thoracocentesis? Means basically, which is an indication for placing an ICD. Okay, so as you know, the pleural effusions are of two types, transudative and exudative, right? So pleural effusions are of two types, transudative and exudative. Transudative, generally we just treat the underlying cause. Transudative can be caused in patients with CLD, CKD and chronic congestive cardiac failure. Okay, so these are the cases where you generally get transudative. Exudative, you have so many causes. Exudative you get when you have pleural tuberculosis. Exudative is what you get when you have parapneumonic or synpneumonic effusion. Okay, so para or synpneumonic effusions, where you have a pneumonia going on and the effusion is a result of pneumonia, parapneumonic effusions. And then tuberculosis and malignant effusions, and also rheumatoid arthritis associated pleuritis can also produce exudative effusion. So these are all exudative causes. Okay, now when do we actually do a tube thoracocentesis, or for that matter therapeutic therapocentesis? When either fluid is too much and causing respiratory distress, or it is some cases of exudative. Transudative is usually managed by treating the underlying cause and giving diuretics. Like if you have CLD, we give diuretics, treat the underlying cause, we give albumin. If heart failure, we give all the heart failure drugs and we do aggressive diuresis. CKD, if diuresis is possible, we do, otherwise we have to go for dialysis. That is how the effusion also comes down. But exudative, if it is TB, we primarily treat it with antitubercular therapy. Malignancy might require ICD placement. Malignancy might also require the fusion of the pleurae so that no fluid accumulates there. RA pleuritis, mostly we treat by treating the underlying cause. When we are dealing with parapneumonic effusion, that means there is an infection of the lung, and as part of the infection, you have also developed effusion. So in such cases, if the infection is bad, we have to do source reduction. Means we have to remove the fluid, otherwise the fluid becomes the source of infection and you keep getting bacteremia from there. Now, how do I get to know that infection is bad? Okay, if I'm getting straw colored fluid, it means I'm mostly having transudative, right? So I shouldn't be worried much about. Okay, so how do I get to know that I have got a bad parapneumonic effusion, which can be called as empyema thoracis? Literally pus there. Visibly pus is there? Yes, it calls for tube drainage. Second, if the pH is less than 7.2, when the fluid is highly acidic, it calls for tube drainage. Third, if the fluid glucose is very low, very low, that also calls for tube drainage. Okay, so now if they're asking presence of straw colored fluid, no. If I rather had got empyema or pus, it calls for tube drainage. Okay, then pleural fluid pH less than 7.2, it calls for tube drainage. Pleural fluid glucose LDH more than 600 calls for tube drainage, while low glucose indicates that you have bad bacterial infection because the bacteria are consuming the glucose. That's why pleural fluid glucose is low. This calls for tube drainage. So among the given options, this makes sense. Okay, now let's go to the next question. A patient with history of smoking presents to emergency room with complaint of breathlessness. So already they're telling me that the patient is non-smoker and is short of breath for last 2 days. On examination, he was found to be cyanosed, already cyanosed, plus bilateral bronchi. ABJ was done, which shows these findings. They are asking what is the underlying diagnosis. Okay, from the context, what comes to your mind? Wheezing is there, bronchi is there, cyanosis is there, smoking is there. So I'm already thinking about COPD as a possibility, but other conditions cannot be ruled out. Smoking doesn't protect you from developing pulmonary embolism or pneumonia or pulmonary fibrosis, right? So we will keep all the differentials open. We will analyze the ABG and then arrive at the diagnosis. pH is 7.12, PaCO2 is 80, PaO2 46, bicarb 29, right? So first thing is pH. So when I look at the pH is less than 7.12 is certainly less than 7.35. So it indicates that we have acidosis. Now I have to just decide whether we have respiratory acidosis or metabolic acidosis. So for that we follow the ROMS approach. I have to just assign a direction to the pH. pH is of course decreased than the normal value, while PaCO2 normal is 35 to 45. Here it is increased than normal. Both of them are in the opposite direction. Both of them are in the opposite direction. And according to the ROMS criteria, respiratory opposite, metabolic same side. So if they are opposite, that is PaCO2 is high, pH is low, they are in the opposite direction. That makes it a respiratory pathology. So we are dealing with respiratory acidosis. Respiratory acidosis. In pulmonary embolism, and if I have respiratory acidosis, that also means that I have type 2 respiratory failure because I have impaired carbon dioxide clearance. So diagnosis here are two things. One, respiratory acidosis. Second, PaCO2 is high. So that means we have type 2 respiratory failure. Okay. Whenever you have pulmonary embolism, whichever part of the lungs, the pulmonary artery branches are blocked, those areas of the lungs are not participating in the gas section. So you end up with hypoxia and not hypercapnia. So you will develop type 1 respiratory failure, pure hypoxic respiratory failure, no hypercapnia. Here hypoxia is there, but hypoxia plus hypercapnia is always type 2, not type 1. So it is unlikely to be the cause. Pneumonia again produces type 1 respiratory failure. Whichever part of the lung is affected by pneumonia is not participating in gas exchange. So you end up with predominantly hypoxia. Then pulmonary fibrosis. Fibrosed lung is not participating in gas exchange. So you end up with hypoxia. So you develop type 1 respiratory failure again. But what I have here is type 2. Type 2 respiratory failure. The most common cause is COPD itself. So I would think of COPD as my diagnosis. And now that question has told me patient was cynosed, I also think he is most likely having chronic bronchitis component of the COPD as the predominant COPD component, because that is where you get the cyanosis, right? On the other hand, emphysema, we call them as pink puffers. They are less likely to be cyanosed, more likely to be having puffed lungs, trying to struggle to exhale the air out, right? Okay, so that's our answer in this case. Now let's go to the next question. A patient with history of chronic smoking presented with breathlessness for last 1 year. On examination, there were bilateral rhonchi in the chest. 1 year history of shortness of breath. He is also a chronic smoker. 1 year history of shortness of breath. Bilateral rhonchi are present, indicating that there may be an obstructive airway disease. Chest X-ray is showing hyperinflated lung fields. So hyperinflated lung fields make me think of emphysema, and already that I know he is a smoker, I am strongly considering emphysema as a diagnosis here. Which of the following parameters of pulmonary function test are consistent with the diagnosis of COPD disease in this case? So in COPD, what happens? In COPD, your forced expiratory volume in 1 second is decreased because you have obstruction, you have difficulty to exhale the air out. So your FEV1 decreases. Okay. Second, if you look at FEV1 by FVC ratio in COPD, being an obstructive airway disorder, it will be less than 0.7, less than 0.7. Okay. And then especially in emphysema, air comes into the lungs easily, but you are having difficulty to exhale it. Air is getting trapped in the lungs. So because of that, what happens? Your lungs total lung capacity increases. So you will have increased total lung capacity. You will also have increased residual volume. You will have increased residual volume. Okay. I think I've also told you in the respiratory modules that in circumstances where FEV1 by FVC calculation is not possible for diagnosis of obstructive airway disorders, what is the next best thing we can do? We can get a peak flow meter and measure the peak expiratory flow rate. Just like how FEV1 is decreased, peak expiratory flow rate will also be decreased in all obstructive lung disorders, including asthma and COPD. So in COPD, you will also have decreased peak expiratory flow rate. Okay. Then one more parameter that we actually use to differentiate between asthma and COPD is going to be your diffusing capacity of the lung for carbon monoxide or DLCO. DLCO is decreased in COPD, while in asthma it is not affected. It can be increased also sometimes, but certainly not decreased. So in COPD it will be decreased. So now that you have all the PFT parameters in front of you, answer it. Decrease FEV1 is expected, yes. Increase diffusing capacity of the lung, no. DLCO is decreased. This is not expected in a COPD patient. It can be increased in patients with, where do I get increased DLCO? In patients with asthma and in patients with pulmonary hemorrhage, like in Goodpasture's disease. Pulmonary hemorrhage, like in Goodpasture's disease. Okay. Now decreased peak expiratory flow rate, yes, this is expected. So now what all are true statements? Increased residual volume, yeah, this is also expected. Residual volume, total lung capacity, both get increased. So that means except 2, 1, 3 and 4 are correct. Do we have one such option? Yes, option B fits the bill, 1, 3 and 4. So that's how we arrive at the answer. Okay, so last question for today. There are more than 80 questions from medicine. Me and my team have compiled all the questions answers, and if you want to know the answers for the remaining questions, if you are watching me on the Instagram, you can comment link and you will get the file on the link. And if you are watching on the YouTube, in the comment section, my team would have pasted a link through which, the Google Photo link through which you can reach the full PDF with all the correct answers mentioned. Okay, the last question for the day, omalizumab is helpful in which of the following diseases? Asthma, idiopathic pulmonary fibrosis, nasal polyps. What is omalizumab? Omalizumab is an anti-IgE. Omalizumab is an anti-immunoglobulin E monoclonal antibody, right? Anti-IgE monoclonal antibody. So in whatever conditions IgE may be playing a pathogenic role, the drug also has a role. In asthma, we definitely have type 2 asthma where IgE is playing an important role, and also various other allergic conditions including nasal polyposis. There may be role of IgE. So then I can use anti-IgE drugs for treatment of asthma and nasal polyposis. It has no role in management of idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is because of the overactivity of the fibroblast. So if you want to suppress the fibroblast, you need to give steroids or immunosuppressants, not the anti-IgE drugs, right? So think of IgE when you think of allergy rather. So 1 and 3. 1 and 3. Okay, option A, we find 1 and 3. So that becomes our answer to Gopar. So that's it from me here. I'll see you again with one more such interesting topic. Till then, have a good time. And please don't forget to comment link on Instagram, or if you're on YouTube, please don't forget to download the link to the remaining questions and their correct answers PDF. See you guys. Bye-bye.